At the outset, I want to thank Dr. Khanna and his team for this wonderful conference, and to see particularly Dr. Henry every time to listen. So nice news. This contrast, every time we are talking of CT, MRI, and other things, and the one or another contrast is used, either iodinated most of the times or gadolinium. Now the carbon dioxide is coming soon. So this, I will discuss what is the advantage, disadvantage, what the precautions we can take. Overview of my talk is introduction, nomenclature, risk factors, contrast medias, clinical characteristics, prevention, and what to do, what not to do, and then a slide of conclusion. You see this, the structure, what we see if you do biopsy, there's a acute tubular necrosis most of the time, and sometimes there's involvement of interstitium and macrovasculature also. The contrast-induced nephropathy is associated with diagnostic procedures, as I told you, associated with increased morbidity and mortality, increased hospitalization time, acute renal failure and dialysis. This is the third most common cause of hospital-acquired infection, this acute renal failure, after hypertension and the surgical procedures. This epidemiology, if you see, the 5% of the patients who are having mild renal insufficiency, they go into the contrast-induced nephropathy. If they are in stage 4 or so, then they go 50%, they go in this CIN, and less than 1% in patients who are normal renal functions. This has been the most frequently used term to describe this is the contrast-induced nephropathy. But nowadays, nephropathy is not being used because nephropathy means proteinuria and other things and the involvement of the kidney by many ways. So acute kidney injury, the recent guidelines by Doki and Digo, they have used the acute kidney injury. And this is contrast-induced AKI, the CI-AKI. If you see the various materials used, barium sulfate, iodine-based, gadolinium and carbon dioxide, most of the studies in this class, they have been with iodinated contrast media. So if you say iodine, contrast-induced AKI, that is a better terminology, because up till now, all these studies which are in meta-analysis or all the single studies, they are with iodinated contrast media. The most commonly defined as the increase in serum creatinine or reduction in GFR within 48 hours. There are a lot of definitions, every center using their own definitions. But what I have taken out, the simple definition for all the cardiologists and nephrologists is, serum creatinine more than 0.5 milligram% within 72 hours, or there is a reduction of GFR by 25% from the baseline. You see the pathogenesis, a single slide. What is the important, what is behind that nephropathy? This is one is, tubular toxicity, direct toxicity of the, contrast, microvascular alteration, oxidative stress, inflammation, and protein precipitation. This is a very important slide when you are going to, suppose a cardiologist know that this patient is having low GFR or a kidney problem. He is very cautious. He uses a minimum dye, 1 or 2 shots or 3 shots, rather than taking 5, 6 shots. So we should know what are the modifiable factors, what are the non-modifiable factors. Non-modifiable factors are the age, the pre-existing renal failure, diabetes, congestive heart failure, hemodynamic instability, nephrotic syndrome, or proteinuria. If you say the GFR, when it comes down less than 60, the incidence is more. And chances are more even if it is less than 40, they are quite good number that they go to contrast-induced AKI. There were scores 10 years back. Now this is not used at the various centers. You know about the contrast media, there is high osmotic, low osmotic, and isoosmolar. The isoosmolar and low osmolar, they are beneficial in comparison to high osmolar. If you see the study where low osmolar and isoosmolar, they are studied, the many studies there is not a significant difference, but when the patient is having chronic kidney disease or diabetes or chronic kidney disease alone, there is a significance, statistical significant difference between the isoosmolar over the low osmolar. What is the clinical characteristic of this when the patient is having contrast-induced nephropathy? It is onset is 24 to 48 hours. Duration is 5 to 7 days. Is non-oliguric most of the time, but many times there's oliguria, there's a stage 4 kidney disease. And dialysis is required rarely if patient is having kidney disease, stage 4, maybe more. Urinary sediments are variable from bland to some proteinuria and few RBCs at the times, and low, fractional excretion of sodium. Now, what are the strategies in the literature and as of now, what we are having? The strategies that do not work at all, mannitol, furosemide, dopamine, and this hemodialysis, prophylactic hemodialysis, they are not useful at all. Strategies that may work, calcium channel blockers, N-acetylcysteine, sodium bicarbonate. The debate is going on. There are studies in favor or against also. What works very well, we know, they employ non-iodinated contrast studies if possible, avoid other nephrotoxic drugs, provide adequate time between contrast procedures, gapping between two procedures, and minimize contrast volume. The hydration is very important, and low osmolar or isosmolar contrast is to be used. Then what is the prevention? Prevention is having multifactorial. One is, the hydration. Previously we were using NY2 around 10 years back. Now we are using normal saline. Seeing the fluid status of the patient is important clinically to see if the patient is in CCF or is fluid overload. So normal saline is good. What we are using, that we use, 12 hours before and 12 hours after. 1 to 1.5 ml per kilogram per hour. This we use, when the patient is hospitalized, and we give IV sodium chloride. The bicarbonate is now coming up. The studies in favor and against, again, as I told you, 5% dextrose with 3 ampoules of bicarb, bolus 3.5 ml per kg in 1 hour pre-procedure, and then 1 ml per kg per hour, 6 hours post-procedure. The prevention of contrast-induced acute kidney injury is simple oral hydration is beneficial or not, because many patients, they walk in for angiography or the studies, they don't be hospitalized to decrease the cost, so the oral hydration is beneficial or not. There are different studies are there, and the meta-analysis, they show that it is not very clear, and we require a big study with the good power to see that oral hydration is as equal as IV hydration. Now, regarding the hydration of sodium chloride and bicarb, again, there are various studies, but one meta-analysis says that sodium bicarb is beneficial over sodium chloride. But recently there was one article from Kilima et al. That the sodium chloride is beneficial. So this debate is still going on, and this is choice of nephrologist and cardiologist team what is beneficial. But by and large, soda bicarb is having little as over sodium chloride at the moment. You see the large trials and small trials. The sodium bicarbonate, and there's some trials no significance, some trials are significance. The total amount of hydration might be more important in, preventing renal failure than the type of agent. So the hydration is more important than the sodium chloride or sodium carbonate or oral hydration. N-acetylcysteine, again, controversial views. We give 4 doses, 600 milligram to 1200 milligram, 3 doses prior to study and 1 dose later. But still, it is not, very much clear. Some studies in favor or against. But it is a cheap drug. It is a non-toxic drug. So particularly in diabetes and chronic kidney disease, we use this drug in all our patients. The other drugs, they are not really very helpful. Dopamine and phenoldiazepam, they are not very helpful. Then IV contrast, we should use IV contrast only when necessary. Hydration is important. Minimize contrast volume is very important. The cardiologist or interventionist, they should know that this patient is having low GFR or low creatinine, so they are very cautious. This is very, very important point. Many times it is not known what is the creatinine, what is the GFR, and they take a routine angios, and a lot of dye is going in that. N-acetylcysteine is, as I told you, we are using. Now we have to see the high risk and low risk group. The patient on diabetes, patient is having renal insufficiency, GFR less than 60, they come into high risk group. So we have to see the hydration should be adequate, all the nephrotoxic drugs should be removed, and they are saline or sodium bicarbonate should be given, plus minus N-acetylcysteine, and low dose of the contrast. In the normal group, we give good hydration, no IV hydration, no pre-procedure antioxidants are required. The only hydration is important, and then the choice of contrast is same as isosmolar or low osmolar, preferably isosmolar if the cost is not a question. What to do? First thing is, when we are going to do a study for a patient, avoidance of the contrast. Ultrasonography, MR without gadolinium, CT without contrast. What we have already discussed, we should go to Dr. Kapoor first for ultrasound if that can be resolved. If it cannot be resolved, then we go for the contrast studies. Then avoidance of the contrast, avoid high osmolar contrast, you avoid it. Use lower doses of contrast. Avoid fluid depletion and NSAIDs. You have to see in prior that patient is getting some nephrotoxic drugs like NSAID, cyclosporin, cisplatinum, or any other drug. Isotonic fluid with bicarb is preferable. N-acetylcysteine, choice of yours. Do not use prophylactic hemofiltration or dialysis after contrast dose because it is in studies not found useful. As no treatment specifically targets CNIN once it develops, the main goal for clinician remains prevention. So prevention is more important than the treatment. The questions, there are 2-3 questions which are unanswered in the literature. One is, should we go for creatine clearance for every patient? In particularly because it's cost effective and this requires a little time. So the patients who are high risk like diabetes, kidney disease, they should be, creatine clearance should be measured. Aged patients, multiple exposure patients. Then there are, other like gadolinium and this, we have to see where the studies is, gadolinium is preferable. Then we have to see the other markers. Now we are having serum creatine, which is very late to increase. So like urinary angel and cystatin, plasma cystatin C can be used as the earliest marker to understand and to take actions for the treatment and prevention. To conclude the session is, one is optimal hydration, as I told you, oral, IV, sodium chloride or sodium bicarbonate, anything, but the hydration should be adequate. Not look after, overlook the overload also in this setting because I see many patients, they are overloaded. The use of lowest amount of contrast media, N-acetylcysteine. Then there is, non-ionic, low osmolar or isosmolar is preferred if the cost is not issue. The last slide to take message at home is, first is clinician status should know, be aware that CIN is a potential serious complication. Suppose patient is having CKD stage 3 or 4, many patients they go to irreversible liver damage and they require RRT after contrast study. Why? If we have not done this study, they might have gone for years together. The second thing is, the risk and benefit should be assessed by the doctor itself and to the attendants, patients, relatives also, patient also, that it is beneficial in this way and this may harm in this way. The third point is, the hydration should be adequate, either oral or intravenous. The stop nephrotoxic medications like diuretics, NSAIDs and chemotherapy. Use only new generation contrast media and use the lowest amount of contrast, and there should be serum creatine to be measured 24 hours to 72 hours, and then if there is a nephropathy to be followed up for a week, and then there should be a gap between 2 studies if possible, if it is clinically it is possible. Thank you very much for kind attention.